that we cannot find it out. That is the unfortunate, you can say, or that is the limitation of the ultrasound. T3, T4, TSH will tell you about the functional status of the thyroid, whether thyroid is working normally or it is not working normally. So these are two different investigations. One tells you about the functional status of the gland, another tells you about the anatomical status, anatomy wise, and something which is you are missing on clinically. So these are the two different investigations. A goiter may be functionally well if you do a T3, T4, TSH. If you find these parameters within normal needs, the gland is working fine. But the goiter is so big that it is pressing over the laryngeal nerve, or the changing the voice, or making a patient breathing difficult with passage, then it means it is so big. At times we have seen these cases where T3, T4, TSH was absolutely fine. The patient didn't bother because most of the time they are reluctant to go for the surgery. They say, I'm fine, why I should go for surgery? But it keeps on increasing and start doing problems with your voice, with your respiration. Then ultrasound can tell you what is the status of the gland, how much is the pressure, where is pressing on the vessels, or all these things. So these are the two different things.
My talk is about ultrasound of sports injuries. The sportsman has got all the joints, as we know, and they can have injuries to all these joints. We will discuss what are the joints and how these sportsmen they get injured, and what are the things we will be getting while scanning different sportsmen. Let's start with the shoulder joint. First is glenohumeral joint. It is multi-axial spheroidal joint, very wide range of movement. This is accomplished by sacrificing bone stability, and stability is obtained through a complex network of closely applied ligaments, tendons and muscles. Stabilizers of the glenohumeral joint are glenoid labrum, joint capsule, glenohumeral ligaments which are superior, middle and inferior. Then we have rotator cuff tendons like supraspinatus, infraspinatus, subscapularis and teres minor. We have got biceps tendon, long head, coracohumeral ligament and coracoacromial arch. Keeping in view the biomechanics, we must know the planes of motion. We have abduction, adduction, flexion, extension, internal rotation, external rotation and circumduction, a combination of the above. With each of these movements, some of the soft tissue stabilizers oppose the movement of the humeral head in that direction. This maintains the humeral head centrally within the joint. During these movements we can have impingements. The supraspinatus muscle and the long head of the biceps muscle contract at the beginning of the abduction to resist superior movement of the humerus. If the balance of these forces becomes uneven, then the supraspinatus and biceps tendons and the subacromial bursa may be compressed between the humerus and the coracoacromial arch. This is the commonest cause of impingement. Usually when we start for scanning of upper limbs, we start with the shoulder and we divide shoulder into interior and posterior compartments. For interior compartment we start with the biceps, long head in the bicipital groove. This is bicipital groove. There is cross section of the tendon of long head of biceps with transverse ligament covering the bicipital groove. You can see the transverse ligament, which is normal in this case. The tendon is normal in the bicipital groove. There is no fluid around it. There is no tear. We can have transverse splits or we can have longitudinal splits. For the beginners who are just getting awareness about the musculoskeletal ultrasound, there is a new thing according to the protocols given by AUM. Previously we were scanning according to our probe planes along the body parts. For example, if this is a longitudinal axis, if we have put a probe transversely, which is not along the fibers of the tendon, we used to say that this is transverse plane. But now it is recommended that in musculoskeletal ultrasound, we will describe a structure according to the fibers. If we are getting this view, we will not have any concern with the probe, how it is placed. We will look at this and we will say this is longitudinal view of a tendon. For example, here we are getting deltoid. We will say this is longitudinal view of the deltoid, regardless of the probe axis which we have placed. Here is again long head of biceps. You can see the bicipital groove, and here you are getting again the bicipital groove along with the long head. It is normal. Then for longitudinal view, you can just move your probe and you can get longitudinal view, keeping the center of that structure of tendon which you want to be elongated. The structure which is important for you, you will keep that in the center of your probe and you will rotate it at 90 degrees and will get the longitudinal view. Here is a case in which the left shoulder was normal, but the right shoulder was dislocated. Even it was dislocated and we could see it clinically. The distance was increased and even the biceps was dislocated. Another case in which right anterior rotator cuff tear and patient had infection. So inflammatory changes were there along with some fluid. An increased area, it was hypoactive. For elbow, there are few causes of painful elbow. For interior, we can have involvement of brachialis causing tendinitis of the brachialis, distal biceps tendon tear, interior capsule sprain. We can have loose bodies. In the posterior compartment, we can have loose bodies, triceps tendon tear, triceps tendinosis, and olecranon bursitis. In lateral compartment of elbow, we look for lateral tennis elbow, osteochondritis dissecans. The medial side, we will look for medial tennis elbow, golf elbow, medial collateral ligament tear, ulnar nerve contusions or subluxation. In elbow tendinosis, there are few pathological stages which include angiofibroblastic tendinosis, which is granulation-like tissues, acute inflammation, no inflammatory cells in tendon itself but in connective tissues, chronic inflammation in which granulation tissue repair in tendons, and degeneration and microfragmentation of the tendons. So these are the 4 stages in tendinosis. If there is triceps tendon rupture, we will get triceps tendon rupture is associated with direct trauma, radial head fracture, olecranon bursitis, steroids, hyperparathyroidism. Coming to hip, we can have sports injuries around the hip which can include muscles. The muscle injuries include involvement of rectus femoris in soccers, sprinters, in skating and ballet players. We can have adductor longus involvement in kicking, iliopsoas in weightlifters, running in snow, running uphill, soccer sit-ups. We can have involvement of rectus abdomini in weightlifting, pole vaulters, tennis players while serving. Hamstrings can be involved in sprinters, in Olympic walk, in karate and gymnastics. Groin injuries are very common in players, like in soccer players. There are different causes of groin pain. The common causes are osteoarthrosis, osteitis pubis, muscle pathologies like tendinitis, muscle tear, adductor or rectus femoris involvement. Can have hernias like inguinal or femoral hernias, conjoint tendon tear, sport hernias. And the miscellaneous causes of groin pain include iliopsoas pathology like bursitis and tendinitis. Hip joint pathologies include labral tears, stress fractures, avulsions, apophysitis, pelvic pathology and spinal pathologies. We look for these things while having groin ultrasound. We look for muscle pathologies, tendon pathologies, bursitis, hip joint effusions and hernias. For muscle pathologies, we have to look along with muscle pathologies for the tendon pathologies. For the muscles, the main muscles are adductors, rectus femoris, iliopsoas and rectus abdominis. There is a case in which there was adductor longus tear. So there will be discontinuity if it is a tear. You have to measure whole of the tendon and then measure the involved area and you can calculate the percentage. If the percentage is less than 33%, then it is a minor tear. If it is more than 50%, it will be a major tear. We can have inflammatory changes or calcifications. For tendon pathologies, you can have tendon tears or tendon avulsions. Calcific tendinitis in gluteus tendons, rectus femoris and adductors are very common. And we can have synaptic iliopsoas tendon, and all these tendon tears are age dependent. There is a case in which there was a tear. You can see the longitudinal view and the